Um, this is a complicated lecture in some way, so please, if you have any questions, interrupt me. I will try to answer to the questions that you may have on this particular interesting topic, which is medullary thyroid carcinoma. So the title of this lecture is Medullary Thyroid Carcinoma, from the discovery of the RET proto-oncogene to the development of tyrosine kinase inhibitors. The program for this presentation will include the definition of the disease, the classification of medullary thyroid carcinoma into two different groups, hereditary and sporadic, the discovery and the recognition of the activity of the RET proto-oncogene, the metabolic pathways that are activated by RET, and the treatment of patients who have medullary thyroid carcinoma with a particular focus on the development of molecular targeted therapies. Medullary thyroid carcinoma, as you know, is a neuroendocrine cancer. This is a tumor that is coming from the parafollicular cells or C cells located in the thyroid gland. And because of that origin, medullary thyroid carcinoma may produce calcitonin. This is a tumor that, historically speaking, has been described as a round and blue cell tumor, as you can see in this slide. This is a tumor that is associated also with an increased deposition of amyloid that, histologically speaking, is characteristic of this particular disease. As a thyroid cancer is quite rare in clinical practice, it is only responsible for 3 to 10% of thyroid carcinomas. However, when compared with other cancers, it is much more aggressive, and it is responsible for about 13.4% of total deaths that are secondary to thyroid cancer. As we discussed yesterday, different from papillary thyroid carcinoma, the incidence and the prevalence of medullary thyroid carcinoma have not changed over time. From a clinical perspective, we can classify medullary thyroid carcinoma into different groups, the hereditary types and the sporadic ones. The hereditary medullary thyroid carcinomas represent about 25 to 35% of all thyroid cancers, medullary type, that we see in clinical practice. In other words, 1 in 3, 1 in 4 patients who present to you with medullary thyroid carcinoma may have a familiar predisposition for this disease. In these patients, for most part, we may see a family history that suggests the presence of this predisposition, as other members in the same family may be affected by medullary thyroid carcinomas, as well as other components of what we call multiple endocrine neoplasia type 2, which is that condition that, hereditarily speaking, predisposes to this disease. The average age of diagnosis of a hereditary medullary thyroid carcinoma is about 30 years, but they may happen as early as 9 months of age to any age then after. There are people who have familiar disease in whom the medullary thyroid carcinoma has been described at age 80, age 85, or even later. The anatomical location of medullary thyroid carcinoma is in the central part of the thyroid gland, at least in the hereditary types. And frequently, these are tumors that are multifocal, bilateral, and this is because of the presence of a C-cell hyperplasia. What is a C-cell hyperplasia? You can see it in this slide. Here you have the C-cells. They are here stained by for calcitonin, and you can see that there is an increased number of C-cells around the follicles. Well, over time, from that C-cell hyperplasia that is linear and diffuse, you may develop a nodular hyperplasia, and you can see here the nodules of C-cells in between the follicles of the thyroid gland. And later, you may see a much more aggressive clinical presentation given by a medullary thyroid carcinoma that clearly infiltrates the follicles of the thyroid gland and destroys the normal architecture of this particular tissue. Now, there are interesting characteristics of medullary thyroid carcinoma whenever it is familiar. And the characteristic that is perhaps much more important of it is the fact that it has a genotype-phenotype correlation. What is the meaning of a genotype-phenotype correlation? The meaning of a genotype-phenotype correlation is that depending on the gene mutation that you may have a clinical presentation that is particular or specific associated with it. And this starts with the classical history of what we call multiple endocrine neoplasia type 2. As I have mentioned to you, familiar medullary thyroid carcinomas are present in the context of multiple endocrine neoplasia type 2. And when you look at the phenotype of multiple endocrine neoplasia type 2, you may see two different types, the type 2A and the type 2B. They have two different aspects in common. Number one, all of them are predisposed to development of medullary thyroid carcinoma. Number two, 50% of them may develop pheochromocytomas or tumors that are neuroendocrine in origin located in the adrenal medulla, in the adrenal glands. In the context of multiple endocrine neoplasia type 2A, however, patients are more prone to develop primary hyperparathyroidism secondary to parathyroid hyperplasia in about 10 to 20% of cases. Patients with multiple endocrine neoplasia type 2B are not prone to develop parathyroid hyperplasia. However, they are prone to develop gastrointestinal and mucosal neuromas that happen in about 98% of all these patients. Is this important? The answer is yes, because if you look at this, there is already a different phenotype established for two different groups of patients who have multiple endocrine neoplasia type 2. The patients who have multiple endocrine neoplasia type 2A here are patients who, for most part, look like normal individuals. They look like most of us. They don't have really important manifestations in physical examination. The only abnormal physical examination abnormality that you may see in some patients with multiple endocrine neoplasia type 2A is given by what you see in this slide. This is what we call a cutaneous lichen amyloidosis. A cutaneous lichen amyloidosis is a very discrete lesion, and that's the reason why I present it here. If you look at the slide, it's quite difficult to identify an area of hyperpigmentation in the upper part of the back of this patient. This is associated with a particular gene mutation in the RET protoncogene. This is a mutation that is located in codon 634, and it only happens in some families, and those families are families that we call families with multiple endocrine neoplasia type 2A associated with the cutaneous lichen amyloidosis variant. But this is the only abnormality by physical exam that we can see in patients with multiple endocrine neoplasia type 2A. Different from multiple endocrine neoplasia type 2A, patients with multiple endocrine neoplasia type 2B will have a much more distinctive phenotype by physical examination, and you can see it in this slide. This slide is showing a very unfortunate young man. This man presented to us at age 15 with a very big tumor that you can see in the central part of the neck. That is a medullary thyroid carcinoma. The patient had other manifestations of the disease. If you look at the tongue of this patient, in the borders of the tongue, you can see multiple ganglioneuromas. In addition, if you look at the lips are thickened, and they are thickened because of the presence of ganglioneuromas in that particular area. In association with that, you may see eye thickening because of ganglioneuromas that are located in the eyelids. In addition, if you look at the eyes of this patient, you will see that they are kind of closed. It seems that the patient has photosensitivity. In reality, the patient doesn't have photosensitivity. What the patient has is simply the fact that it's bothered by the presence of ganglioneuromas in that particular area that irritate the eyes. If you look at the chest of the patient, this is a boy that is not really a muscle man. However, if you look at the chest looks wide. Yes, this patient had a deformity that we call the shield chest deformity. The chest looks like a shield. Look at the ears. The ears have a low setting. Those are characteristics that we have in patients with multiple endocrine neoplasia type 2B. So again, if you look at patients with multiple endocrine neoplasia type 2, you will see that the type 2B will have a distinctive phenotype, while patients with type 2A, for the most part, look like normal individuals. Now, they have in common, however, the presence of medullary thyroid cancer in 100% and pheochromocytomas in 50% of them. So why they have those common characteristics? Well, they have those common characteristics simply because they share abnormalities in the same gene. The gene that is responsible for multiple endocrine neoplasia type 2 is the RET proto-oncogene. This is a gene that whenever affected by activating mutations, may induce the increased and abnormal cell proliferation of the C cells, predisposing to medullary thyroid carcinoma, as well as to pheochromocytomas, ganglioneuromas, and parathyroid hyperplasia, as we have discussed before. And it was quite interesting because this is a gene that was discovered by 1987 as a gene located in the chromosome number 10. By 1990, the gene was discovered to be associated in a particular area in the center of that chromosome, so it's a centromeric gene. And by 1993, the gene was finally discovered as responsible for the expression of the RET protein. The RET protein is what you see here. This is a protein that is located in the cell membrane. This is a tyrosine kinase receptor. It is a protein that regulates cell proliferation, cell transcription, cell differentiation. It is important under normal conditions to allow the formation of the central, the peripheral, and the autonomous nervous system. So our central, peripheral, and autonomous nervous system are there and are normal in part because of the activity of the RET proto-oncogene during the embryonic life. When you look at the characteristics of this protein, the protein is characterized by an extracellular domain, which is very rich in cysteine. There is an intracellular domain that we call the tyrosine kinase domain. There is an anchor domain that places the receptor on the cell membrane, and there is a domain of communication with other cells that is located in the most external part of the extracellular area. As many of the tyrosine kinase receptors, this receptor, in order to become activated, needs to be dimerized, and that dimerization is the one that is going to allow the activation of the MAP kinase pathway in a modulated or regulatory way. Now, in patients who have multiple endocrine neoplasia type 2A and multiple endocrine neoplasia type 2B, the receptor becomes abnormal. Patients who have multiple endocrine neoplasia type 2A, we have mutations that may be located either in the tyrosine kinase domain or located in the cysteine-rich domain. And what they do is they simply facilitate the dimerization process of the receptor. The facilitation of the dimerization without the control of any particular hormone will activate abnormally MAP kinases that will predispose to the development of, again, medullary thyroid cancer, in some patients pheochromocytomas, and in occasional patients primary hyperparathyroidism. In patients with multiple endocrine neoplasia type 2B, the situation is different. There are mutations in the same gene that are different from the mutations that we see in multiple endocrine neoplasia type 2A. Those mutations are located in the tyrosine kinase domain and different from the ones that we see in multiple endocrine neoplasia type 2A. The ones in type 2B will activate the receptor without the need of dimerization. So it is a much more effective process, if you want to call it like that. And because of that, these patients are going to develop, again, medullary thyroid carcinomas, but different from the ones that we'll see in multiple endocrine neoplasia type 2A. The ones here appear rapidly, faster, and they are more aggressive in clinical presentation than in the others. So this is the pathogenesis of what we call a multiple endocrine neoplasia type 2A and type 2B medullary thyroid carcinoma. Now, this is very important because this is what is going to tell you how we treat in a prophylactic manner patients who have medullary thyroid cancer disease. As we have described, these patients have a genotype-phenotype correlation. This is a complicated table. We are going to review it again in the second lecture on this particular topic. And here what we have is the American Thyroid Association classification for medullary thyroid carcinoma and RET proto-oncogene mutations. Here we have mutations that we call risk A in light blue, risk B in dark blue, risk C in pink, and risk D in red color. What it is important here is that the mutations that are considered risk D are considered more aggressive in clinical practice, while the mutations that are considered risk A are the ones that are associated with a much milder phenotype of medullary thyroid carcinoma. So, for instance, what are the mutations that belong to the category D? These are mutations that are located in codons 918 and 883. Which are those mutations? The ones that predispose to multiple endocrine neoplasia type 2B. which is considered the most aggressive type of medullary thyroid cancer in general in clinical practice. Then we have category C, which is pink. These are mutations that are considered aggressive, and they only happen in a particular codon, codon 634. These are patients in whom the medullary thyroid carcinomas may have an early presentation and an increased risk to develop distantly into organs such as the liver, the lungs, and the bones. Then you have the mutations that are in category B. They include a large number of mutations. That's why they are majority in this table. And we have here mutations in codons such as the 611, the 620, the 618, and the 609. These patients have a less aggressive clinical outcome. And finally, we have mutations in category 8, which are considered the most benign mutations, although we have to be careful with that particular name because they are not benign. They predispose to cancers, and those cancers still can kill the patient, simply that the presentation of the cancer is rather slow when compared with the others, and include mutations such as mutations in codons 768, 891, 790, 791, and 804. So I'm giving you the names because theoretically, when you become an expert on medullary thyroid carcinoma, you should know which mutation in particular your patient has in order to predict how you are going to treat and how the prognosis of your patient may be. And why is that? If you look at this interesting table, you will see that this mutation is going to tell you exactly how the medullary thyroid cancer will behave in regards to the spread into lymph nodes and distant places in our bodies. In this graphic, again, we are going to see several mutations. Category A, according to the American Thyroid Association, located in the left side. Category B, followed by category C and category D. We are going to see lymph node metastasis here in brown and distant metastasis in pink. If you look at patients who belong again to category D, multiple endocrine neoplasia type 2B, red proton gene mutation 918 and 883, you will see that distant metastasis may happen in these patients as soon as age 4, 5, 6 years after being born. So these are quite aggressive, and lymph node metastasis may happen approximately by 6, 7, 8, 9 months of age. This is one of the most aggressive types of medullary thyroid cancer we have in clinical practice. If you look at category C, lymph node metastasis may happen around age 5. Distant metastasis may happen just early as age 10. If you look at category B, the distant metastasis may happen much later, and in category A, distant and lymph node metastasis usually happen after age 20. So these are patients in whom the disease exhibits a much slower growth in clinical practice when compared with others. What is the relevance of this? Well, from a pragmatic perspective, that's the reason why, for patients who have multiple endocrine neoplasia type 2, we recommend a prophylactic total thyroidectomy. Why is that important? Number one, you have to remember that all patients who have multiple endocrine neoplasia type 2, 100% of them will develop medullary thyroid cancer. So why not to do a total thyroidectomy in order to prevent the development of that particular disease? The question is then when to do it and how to do it. Well, the type of mutation that the patient has is going to tell us exactly when and how to do it because it's telling us about the aggressiveness. We have to remember that we are going to remove the thyroid gland, and these are people who may develop medullary thyroid cancer when they are children. And it is important to have the thyroid gland active when we are children. And it is important because it determines our physical development and, very important, our mental, neurological development. So we have to preserve it as much as we can. And based on that, we have classified the mutations as A, B, C, and D. And for each one type of these mutations, we recommend total thyroidectomy plus minus lymph node dissection at particular times. So let's go back again. Mutations that belong to category D, these are the most aggressive ones. These are children in whom we have to do, if possible, a total thyroidectomy as soon as possible, as soon as we identify the patient. And if we know of this patient early in life, we have to do it even in the first months after being born. So for these patients, we need to have a very experienced surgeon because these patients may develop hypoparathyroidism because of surgery, and it could be quite complicated to treat a hypocalcemia in a baby. So this is an important concept that we have to keep in mind. Number two, patients who belong to category C, mutations in codon 634. As we saw in the previous graphic, lymph node metastasis may happen by age 5. So when to do a total thyroidectomy? Before the lymph node metastasis I develop, before age 5. That's the time of doing it. For category B, you may consider surgery before age 5. However, there are families in which these mutations are not that aggressive, and in those patients you may be a little bit more conservative, and you may offer surgery after age 5 as long as the ultrasound of the thyroid gland is normal, as long as the calcitonin is normal, as long as the family history suggests that the disease is less aggressive. For category 8, you may do it at a much later age. It is unclear exactly when to do it, but you may continue using the same parameters of follow-up that we described for category B in order to determine when to do a total thyroidectomy for all these patients. So as you see here, the genotype, phenotype characteristics of multiple endocrine neoplasia type 2 have a huge impact on how we practice for these patients. Now let's move into a sporadic medullary thyroid carcinoma. 65 to 75% of patients with medullary thyroid carcinoma are sporadic and they are not familiar. Different from familiar medullary thyroid carcinoma, the age of presentation is later, 49 years of age. They don't have a personal or family history suggestive of hereditary disease, and they don't have germline RET mutations. That's why they are not familiar. There is no C-cell hyperplasia. 10 to 20% are bilateral. Frequently, they are aggressive and they exhibit intrathyroidal spread. They are associated with lymph node metastasis in 50 to 80% of these patients. Reason why, for everybody who has a sporadic medullary thyroid cancer, we recommend an ultrasound of the neck and a CT scan of the neck with contrast. Now, an important concept, although they are not familiar and they don't have germline mutations, up to 60% of them have somatic mutations in the red proton gene. In other words, the tumor is mutated, therefore, the pathophysiology of sporadic medullary thyroid carcinomas in many cases is similar to the pathophysiology that we see in multiple endocrine neoplasia type 2 cases. Another important concept is that patients who present with sporadic medullary thyroid cancer, in up to 6 to 7% of them, there is a familiar predisposition that is not quite obvious. What is the meaning of that? That whenever you see someone with medullary thyroid carcinoma, the patient needs genetic counseling, and you have to offer red proton gene testing, regardless of how the family history of the patient was. Where are the metastases of medullary thyroid carcinoma? And this is common to sporadic as well as familiar. The metastases of medullary thyroid carcinoma happen in lymph nodes, liver, lungs, and bones. They are metastases that occur because of lymphatic spread and hematogenous spread. Now, they follow a particular order in general. Initially, it starts with the lymph nodes, then it goes to the liver, then to the lungs and bones, although you will see some exceptions in clinical practice. How do you know if the patient has metastasis? As I mentioned to you at the beginning, one of the markers of medullary thyroid carcinoma is calcitonin in plasma, and the values of calcitonin will help us to tell where the metastatic disease may be located and how to study those metastases. So whenever you see a calcitonin value that is less than 200 picograms per ml, the disease is practically or exclusively located in the neck. And for those patients, you only need to order an ultrasound of the neck or a CT scan of the neck with contrast. Ideally, a combination of the two. Remember that the ultrasound is very good to evaluate the anterior part of the neck, but it has limitations in the posterior part that you may identify easily with the CT scan of the neck. Whenever the calcitonin values are in between 200 and 1,000, it's possible that the patient only has disease located in the neck. However, in many of these patients, you may see disease in the liver, lungs, and bones. And for those patients, apart from the exams that we order for the neck, we may need to do a liver CT scan with liver protocol, lung CT scan, and bone scan. Whenever you see a calcitonin value that is higher than 1,000, most likely there is distant disease And in all those patients, you need to order a combination of tests, ultrasounds and CT scans of the neck, liver scan with liver protocol, lung scan, and bone scan. Look at this. I didn't mention any nuclear medicine studies simply because nuclear medicine studies in the context of medullary thyroid carcinoma so far seem to have a limited value in the evaluation of the disease. Let's talk about survival based on disease extension. As we described with other types of cancers, of course, when you have a disease that is localized in the neck, that's the best chance for you to have an excellent response to therapy. The survival rates at 10 years are really quite good. More than 95% of these patients will be alive. When the disease is associated with lymph node metastases in the neck, this is regional disease, the survival may be compromised after 10 years. Only 80% of them will be alive. But when you have distant disease, the survival rates are much lower. At 5 and 10 years, 50% of these patients will be dead. And to finalize, let's review what is novel in the treatment of medullary thyroid carcinoma, surgery and molecular targeted therapies, a brief slide for surgery. The only way to cure medullary thyroid carcinoma is whenever you are able to resect it. Surgery is very important for local disease with a total thyroidectomy. Remember that these are tumors that have a possibility to be bilateral and to exhibit intrathyroidal spread. When you do a total thyroidectomy, it's important that the surgeon removes many lymph nodes because it's a tumor that millimeter by millimeter may be able to spread into lymph nodes. When you have regional disease, there is still a possibility that you can cure it with surgery, although some patients are not. These are cells that are very small, that may be located in the lymphatics in between the lymph nodes, and the surgeon may not see them, or may be just impossible to completely be resected initially. So with regional disease, there is a big chance that you may not even cure the disease with surgery. And when you have a distant disease, surgery is not curative. However, it may prevent complications in the neck. This is an important aspect because historically speaking, medullary thyroid carcinoma kills usually because of neck disease. So even if you have distant spread, try to do surgery for the disease in the neck if you can. Let's talk about molecular targeted therapies. As we described, medullary thyroid carcinomas uses the RET proton gene and this receptor to activate the MAP kinase pathway through RAS, BRAF, MEK, and ERK, as well as the PI3 kinase pathway. And this is the mechanism of abnormal cell growth on patients with medullary thyroid cancer. This is also activated by the epidermal growth factor receptor, by the c-Met receptor, and the angiogenesis factors, such as the vascular endothelial growth factor receptor number 2. And these are places that we can target in clinical practice. How do we do it? We currently have 2 medications to treat patients who have distant medullary thyroid carcinoma. One of them is Vandetanib. Vandetanib is approved for the treatment of medullary thyroid cancer in the US. It is an inhibitor of RET, EGFR, and vascular endothelial growth factor receptor. Therefore, you may modulate and inhibit the activity of the PI3 kinase pathway and the MAP kinase pathway. It has proven to be effective in a phase 3 clinical trial that is called the ZETA trial, in which when compared with placebo in a group of patients with Vandetanib, it became obvious that Vandetanib was associated with a reduction in tumor size, as you can see in this slide, baseline located in the left side when compared with follow-up in the right side. Patient in whom the marker calcitonin markedly decreased from 7,000 values to 3,000 values. Now, the ZETA trial demonstrated that Vandetanib was able to improve the progression-free survival of patients with medullary thyroid carcinoma. You can see the progression-free survival of patients with Vandetanib when compared with placebo. And you can see that there is a statistical significant difference, reason why the FDA approved Vandetanib for the treatment of this disease. But this is not the only medication that we have approved for the treatment of medullary thyroid carcinoma. Cabozantinib is another very interesting drug. This is a drug that inhibits RET, the vascular endothelial growth factor receptor number 2, and very important, the c-Met receptor. This is very important for distant spread. This is a drug that was studied in what we call the Phase III exam trial, in which we compare Cabozantinib with placebo, and similar to Vandetanib, Cabozantinib was associated with a pronounced improvement in progression-free survival. You can see here in blue, patients treated with Cabozantinib, in yellow, patients who were treated with placebo. The progression-free survival for Cabozantinib was 11.2 months, and placebo was only 4 months. Because of this, the drug was approved for the treatment of medullary thyroid carcinoma. Of interest, in patients with RET mutations, Cabozantinib demonstrated to be quite effective. You can see the progression-free survival again, and the survival rates. This is the only drug so far that has demonstrated improvement in survival activity in patients with medullary thyroid carcinoma, at least whenever they are RET mutation positive, either somatic or familiar. Whenever they are negative, we didn't see a difference. It seems that the RET mutation determines if the drug will respond or not, if the patient will respond to the drug or not. There is a group of mutations that I haven't mentioned to you that are associated with medullary thyroid carcinoma, the RAS mutations, and in patients who have RAS mutations, the progression-free survival with Cabozantinib markedly improved when compared with placebo. The progression-free survival in Cabozantinib group was 47 weeks, while in placebo was 8 weeks. So we have 2 different therapies for the treatment of medullary thyroid carcinoma, which is a remarkable, outstanding progress made on this disease for which we didn't have anything about 3 or 4 years ago. Now we are able to treat these patients, and the question is, when do we use each one of these drugs, and how do we use it? We use these medications whenever we see someone with progressive disease and someone with symptoms that we cannot control because of the extension of the disease that the patient may have. If the disease is quiet, despite the fact that it's extensive, if the disease does not progress, which may happen because this is a neuroendocrine tumor, then you don't need to treat these patients with Cabozantinib or Vandetanib. So please remember the indications. Now, how do you choose in between the drugs? Currently, there are no studies that compare the two. The only way to choose in between the two is by looking at the side effects. The side effects are quite common for both of them. They include gastrointestinal disease, skin manifestations, constitutional symptoms such as fatigue, lethargy, lack of energy, and many other different things. However, there are some side effects that are quite unique of these drugs. Cabozantinib is associated with bleeding because of perforation or because of fistula formation. Vandetanib is associated with a prolongation of the QT interval. So we choose the drugs based on what are the risks the patient may have for prolongation of the QT interval or for bleeding and rupture. So for instance, if patients have a long QT syndrome, or if the patient has problems with electrolytes, such as hypokalemia, hypocalcemia, hypomagnesemia, or drugs that predispose to a long QT syndrome, we prefer to use Cabozantinib. If the patient has a history of sudden death, we prefer to use Cabozantinib. If the patient has, for instance, a tumor that is located in the chest, predisposing or at risk to have a fistula with the trachea or a fistula with the esophagus, we prefer to use a drug such as Vandetanib. If you have a patient who has diverticulosis or Crohn's disease that may predispose to bleeding, you prefer to use a drug such as Vandetanib. So that's the way we practice currently in clinical practice in the treatment of medullary thyroid carcinoma. So to conclude, medullary thyroid carcinoma is an example of a disease that is caused by a unique gene defect. The recognition of RET has allowed us to classify the disease based on genotype and phenotype correlations and clinical associations and prognosis. It has helped us to establish the follow-up, the test for diagnosis. Very important, we are able to prevent medullary thyroid carcinoma, and also very important, we are able to treat advanced medullary thyroid carcinoma. And these are the people who in our institution work on this particular disease. And as usual, from the University of Texas, MD Anderson Cancer Center in Houston, I am at your service. Thank you.